Okay, welcome to the deep dive. So today we have a pretty specific mission, really tailored for you, the massage therapy student,
hmm
especially if you're at that point where you want to move past just memorizing anatomy charts and, start applying it clinically.
Right, making it practical.
Exactly.
Yeah.
We're going to take these nerve plexuses, which can seem really dense, right? Those complex electrical blueprints,
Yeah, they can be intimidating.
and connect that knowledge like immediately to evidence-based ways to treat three super common nerve compression issues you're definitely going to see.
Carpal tunnel, thoracic outlet, and piriformis syndrome.
You got it.
And that anatomical blueprint, it isn't just theory, it's genuinely your roadmap for effective treatment. We're going through the sources today to shift your focus.
Okay.
So you're not just naming spinal nerves, but really understanding why these regional nerve issues, these peripheral neuropathies, show up where they do.
And crucially, how your hands-on techniques can actually target those compression points precisely.
That's the goal.
Okay, let's start with the foundation then. Spinal nerves.
The basic.
We know, 31 pairs coming out laterally from the spinal cord segments.
Yep.
And they're mixed nerves, right? Both sensory and motor.
Absolutely. Carrying information both ways.
Now, most students, they've memorized the connective tissue layers around the nerves, epinurium, perinurium, and
Like
denurium.
neuriums, yeah.
But why should you, as a therapist, actually care about these layers in practice?
Good question. Because those layers are, well, they're what we're physically influencing when we do manual therapy, when we introduce movement or traction.
Okay.
Think of them like insulation around a wire. They give structure, protection, but they also have to glide relative to the muscles, bones, fascia around them.
The gliding aspect.
Exactly. If that epinurium, the thick outer collagen layer, gets stuck, maybe from trauma or just chronic tension, the nerve can't slide like it needs to.
Okay, so restricted mobility of the nerve itself.
That's a key part of nerve irritation, absolutely. That restriction.
Wow, okay. I hadn't really thought about the continuity of those layers quite like that. It gives us a physical handle on nerve work, doesn't it?
It does, a tangible target.
And linking back to the spinal nerve roots, that brings us to dermatomes. That specific skin patch supplied by just one pair of spinal nerves.
Right. And the dermatome is a primary assessment tool for you.
How so?
Well, if your client reports numbness or tingling that follows a really clear dermatomal map, you know you're likely dealing with an issue closer to the spine, probably at the nerve root level itself before it joins the plexus.
Okay, proximal.
But most of the neuropathies we treat commonly, like carpal tunnel or piriformis syndrome, they're more regional losses. The compression is happening further out, distally.
Affecting the whole area supplied by that peripheral nerve after the roots have mixed together.
Precisely, after they've formed that complex network.
Which brings us right to the networks themselves. The nerve plexuses. Why does the body even do this? Build these complex, interwoven junctions, blending fibers from different spinal nerves.
Why not just straight lines, right?
Yeah. Why complexity?
The main reason is redundancy, especially for movement in the limbs. It's like having backup power lines.
Okay. Redundancy.
How? Imagine, say, the brachial plexus feeding your arm. If one spinal root gets compressed, maybe C5 is having a bad day.
Right.
The other roots contributing to the same nerves, like C6 and C7, their fibers are all mixed in there too, so they can partially compensate.
So the structure, like the hand, doesn't completely lose function just because of one upstream issue.
Exactly. That blending provides resilience.
That makes a ton of sense. And the four big ones are the cervical plexus, C1 to C5.
Brachial, C5 to T1.
Lumbar, T12 to L4.
And sacral, L4 down to S4.
Perfect. Okay, let's zoom in on the brachial plexus then. C5 to T1. This is the network controlling pretty much everything in the upper limb, pectoral girdle, upper back.
Yeah, it's a big one, often described as a spaghetti junction of nerve.
Wait, yeah.
But it actually follows a really strict pattern. You start with the roots, the anterior rami.
Right.
They merge to form three trunks, superior, middle, inferior.
Okay.
Then those trunks reshuffle their axons into divisions, and those divisions merge again to create the cords, lateral, posterior, and medial.
Cords, named for their position.
Exactly, named relative to the axillary artery, a key landmark there. And it's those cords that finally give off the major peripheral nerves we know.
Musculocutaneous, axillary, radial, ulnar.
And, really important for our next topics, the median nerve.
So that whole structure, roots, trunks, divisions, cords, it's not just academic. That arrangement actually creates points of vulnerability, doesn't it?
Absolutely it does. Those cords being named relative to the axillary artery shows just how closely packed everything is in the neck and shoulder region.
Like through the scalene triangle.
Precisely. The scalene triangle, the space under the clavicle, the costoclavicular space, these are tight passages.
And that's exactly why they're prone to compression, which leads us right into thoracic outlet syndrome, or TOS.
Yep, we'll circle back to TOS.
Okay. But let's follow that nerve highway down the arm first. Past the shoulder, down to maybe the biggest choke point, the wrist.
The carpal tunnel.
Let's talk carpal tunnel syndrome, CTS, involving that median nerve we just mentioned.
Right.
We know the basic story. Nerve gets compressed in that small tunnel, usually because the flexor tendons running alongside it are swollen, often from repetitive stress.
And here, the research, the sources we looked at, give us really excellent, specific, data-supporting manual therapy. It's quite strong.
Oh, good. Like what?
Well, we have studies showing that targeted massage, specifically combined with trigger point therapy,
Okay.
delivered consistently, like 30-minute sessions twice a week for 6 weeks.
Twice a week, 6 weeks. That's specific.
Yeah, and it resulted in significant improvement, not just in how severe the symptoms felt, but actual functional status, how well people could use their hands.
Wow. And how quickly did they see results?
Measurable changes were seen by the 2-week mark in that study.
2 weeks. That's pretty fast for something potentially chronic. That dosage, twice a week for 6 weeks, it suggests we're doing more than just relieving temporary pain, right?
Exactly. It implies we're aiming for maybe tissue remodeling, longer-term functional shifts,
Yeah.
not just a quick fix.
So what's the thinking behind why it works? What's the specific mechanism here? It's got to be more than just general forearm rubbing.
Oh, definitely. It has to be specific. So first, you're physically reducing tension in those long flexor tendons.
The one's crowding the nerve.
Right. And in the forearm, muscles and fascia connected to them, you're creating space in that tight tunnel.
Okay, mechanical decompression.
Second, you're treating active trigger points in the wrist, in the forearm. Think flexor carpi radialis, for example. These often refer pain right into that median nerve distribution.
Ah, the referral patterns.
And third, maybe the most overlooked part, you're improving local circulation. Better blood flow helps reduce the swelling, the inflammation that's causing the compression in the first place.
Makes sense. Less swelling, less pressure.
And the studies showed that this targeted approach led to measurable gains in grip strength, something that general massage protocols didn't achieve in comparison studies.
That specificity point is key. Okay, compelling evidence for CTS. Now, let's backtrack a bit, travel proximally up the arm again, back to that neck and shoulder area you mentioned.
That's thoracic outlet.
Right. Let's dive into thoracic outlet syndrome, TOS. This one often presents with those classic neurogenic symptoms, doesn't it? Numbness, pain, maybe pins and needles.
Paresthesia, yeah. Often felt down the arm into the hand and fingers, following the path of the brachial plexus nerves.
So with TOS, we're back at those vulnerable spots we talked about, where the brachial plexus cords are exiting the neck area.
Exactly. The common compression points are usually between the scalene muscles, that interscalene triangle,
Hmm.
or in the costoclavicular space, pinched between the collarbone and the first rib.
Or sometimes under pec minor.
Or compressed under the pectoralis minor muscle, absolutely. Especially if posture is contributing, like rounded shoulders.
So it sounds like for TOS, we're really chasing muscle tightness, hypertonicity, and maybe postural issues as the main culprits.
That's generally the case for the neurogenic type of TOS that massage therapists often see, yes.
What does the evidence suggest works best from a manual therapy perspective here?
Well, large-scale randomized controlled trials, like the ones for CTS, are a bit less common for TOS. But the detailed case reports we have are really quite positive.
Okay, case reports can still tell us a lot. Any examples?
Yeah, there was one specific example cited where just 6 bodywork sessions spread over 8 weeks.
6 sessions, 8 weeks, similar time frame.
Right. Using a combination of techniques, neuromuscular therapy, massage, myofascial release.
A multimodal approach.
Yes, it resulted in sustained improvements, better posture, increased range of motion, and significantly less numbness. And importantly, these improvements lasted for over a year after the treatment ended.
Over a year from just 6 sessions. That's impressive. So if I'm understanding this right, the goal with TOS is maybe less about just stretching a tight muscle,
Right.
and more about strategically sort of remodeling the local tissue environment, creating space for that whole neurovascular bundle to pass through without getting squeezed.
That's a great way to put it. You're targeting the primary offenders, often the tight scalens, which can pull up that first rib,
Okay.
and the shortened pec minor, which pulls the shoulder girdle forward and down. Both of those actions effectively shrink the outlet space.
So by relieving that muscle tension, maybe addressing fascial restrictions around the clavicle or first rib, and encouraging better posture.
You're literally decompressing those neurovascular structures. You're opening up the thoracic outlet.
Perfect. Okay, brilliant connection between the brachial plexus anatomy and treating both CTS and TOS. Let's completely shift gears now. Travel down the body.
Down to the low back and pelvis.
Right, to the lumbosacral region,
Yeah.
focusing now on the sacral plexus. Runs from L4 all the way down through S4.
And this plexus gives rise to the big one, the largest nerve in the body.
The sciatic nerve.
The sciatic nerve, yeah, huge nerve, travels down the back of the thigh and eventually splits into the tibial and fibular nerves further down the leg.
And understanding its relationship with the deep hip rotator muscles back there is critical for our next condition,
Absolutely essential, especially its relationship with one muscle in particular.
which is the infamous piriformis syndrome,
Hmm.
that condition that often mimics true lumbar sciatica. But the problem isn't the spine, it's the piriformis muscle itself irritating the sciatic nerve.
Exactly. The nerve usually passes right next to, or sometimes in anatomical variations, through the piriformis muscle belly. So if that muscle is tight or in spasm.
It clamps down on the nerve.
Okay.
So what specific manual approaches does the research point to for piriformis syndrome? Is it just stretching the muscle?
Stretching helps, but the clinical evidence we reviewed really highlights that targeted tissue work, specifically involving friction, seems key.
Friction. Interesting. Tell me more.
Well, one study directly compared cross-friction massage, or CFM, against just stretching alone for piriformis syndrome. And it found that the CFM group had significantly better results in reducing pain and improving function compared to the stretching-only group.
So cross-friction was superior to stretching alone.
Yes. And furthermore, another approach combined deep friction massage with muscle energy technique, MET.
MET.
And that combination led to improvements in pain, disability, and also, importantly, hip internal rotation range of motion, which is often limited when the piriformis, an external rotator, is tight.
Okay, so for the students listening, we're hearing acronyms like CFM and MET being effective. Can you quickly unpack why cross-friction massage would be particularly useful for something like the piriformis?
Sure. Cross-friction massage, CFM, it's a very specific, deep technique. You apply it perpendicularly across the direction of the muscle or tendon fibers.
Okay, across the grain.
Exactly. So for the piriformis and maybe the surrounding gluteal muscles, the goal of CFM is to sort of manually break up any adhesions or fibrotic tissue, maybe release trigger points.
Stuff that might be physically sticking to or irritating the sciatic nerve sheath?
Precisely. You're trying to restore that necessary glide between the muscle and the nerve.
Got it. And how does muscle energy technique, MET, differ from just, say, passively stretching the piriformis?
MET is quite different. It's an active technique, meaning the client participates. It usually involves having the patient gently contract the target muscle, the piriformis in this case, against your resistance for a few seconds.
Okay, an isometric contraction.
Right. And then they relax, and you gently guide them into a new range of motion, a new stretch. This process uses post-isometric relaxation.
Which does what, neurologically?
It effectively helps to reset the muscle spindle, reducing the muscle's tone or hypertonicity. It often allows for a greater, safer stretch and reduction in tightness than just passive stretching alone. You're using the body's own reflexes to help relax the muscle.
Okay, so you're using neurology to inhibit the muscle that's causing the compression. That's clever.
It can be very effective.
But going back to friction, you mentioned earlier a caution about using deep pressure in acute flare-ups of piriformis syndrome. That sounds a bit contradictory. If friction is key, why hold back?
Yeah, that's a really important clinical point, because if the sciatic nerve is already highly inflamed, really irritable, what we call an acute flare-up,
Wait.
going in too aggressively with deep friction directly over the nerve or the most irritable part of the muscle can actually act like pouring gasoline on a fire. It can make things much worse.
Ouch, okay. So what's the strategy then?
The sources generally advise a more cautious approach initially in those acute phases.
Yeah.
Treat the surrounding soft tissues first, the other gluteals, maybe low back muscles, hamstrings. Use gentler techniques like broader massage, perhaps some positional release, or MET carefully applied to calm down the muscle spasm and hypertonicity first.
Address the neighborhood before going right to the source of the irritation.
Exactly. Once things have calmed down a bit, then you can gradually introduce more specific techniques like CFM directly to the piriformis, monitoring the client's response carefully. You want to avoid causing a significant flare-up.
That's a critical piece of clinical reasoning for any therapist in training.
Hmm.
Okay, so we've mapped the C5-T1 brachial plexus to effective strategies for CPS and TOS,
Hmm.
and the L4-S4 sacral plexus, specifically the sciatic nerve and piriformis, to the benefits of targeted friction and MAT2. When we step back and look at the research across all three of these common compression syndromes, what are the big picture takeaways, the trends that emerge?
The synthesis is actually remarkably consistent across the board. Two things really stand out: specificity and combination.
Specificity and combination.
Yeah. Targeted massage techniques, things like deep friction, cross fiber work, maybe muscle stripping along specific muscles, trigger point release, they consistently show better results, better functional improvements than just generic full body relaxation protocols.
So knowing your anatomy and targeting the involved structures pays off.
Absolutely. The nervous system seems to respond best to precise intervention, not just general pressure.
And the combination factor. What does that mean in practice?
It means that massage therapy alone is good, but it's often better when combined with other approaches. The best results tend to come from a combination strategy,
Yeah.
like combining your targeted manual therapy with specific stretching protocols, perhaps some movement re-education, definitely postural correction advice, and sometimes even targeted strengthening exercises for weakened opposing muscles.
Addressing the whole functional picture.
Exactly. And the dosage factor keeps coming up too.
Right, we saw that with CTS and TOS.
The success seen in protocols that require multiple sessions over several weeks, like that twice a week for 4 to 6 weeks pattern, strongly suggests we're dealing with underlying chronic mechanical issues. We're facilitating actual tissue adaptation, not just providing temporary relief.
Okay, let's try to nail down a summary then. Based on the sources we looked at, what can we confidently say about the outcomes?
Okay, I think we can confidently state that targeted manual therapy is a really viable conservative option for people with mild to moderate carpal tunnel syndrome. It demonstrably improves pain, function, and even grip strength.
Good. What about TOS?
For thoracic outlet syndrome, especially the common neurogenic type, massage looks highly promising as an adjunct therapy. It's effective at addressing the underlying muscle tension, fascial restrictions, and postural components, leading to better range of motion and symptom relief.
And piriformis syndrome.
For piriformis syndrome, we have good evidence supporting those specific techniques. Deep friction massage and muscle energy techniques, especially when combined with stretching and movement re-education, seem very effective for improving pain, disability, and hip mobility.
That's a solid summary of the positives, but, we're always learning. Where are the gaps? Where does the research still need to go regarding manual therapy for these nerve issues?
Oh, there are definitely still questions. One big area is getting more concrete data that directly links manual therapy to measurable structural changes.
Like seeing the nerve decompress on an MRI after massage.
Exactly. Isolating long-term structural changes, maybe reduce nerve swelling on ultrasound or
Yeah.
increase space in the carpal tunnel via imaging that we can say are solely due to the massage intervention. That's tough research to do, but valuable.
Yeah, isolating the variable.
And we still need more work on standardizing the optimal dosage. What's the ideal frequency, intensity, duration, and specific technique combination for different severities of nerve compression?
Yeah.
Is twice a week for 6 weeks right for everyone? Probably not.
Tailoring the treatment more precisely.
Right, which is why in your own practice, it's so important to use validated outcome measures,
Right.
pain scales, functional questionnaires. Track your client's progress objectively over time. See what's working.
Always be assessing and reassessing. Good advice. So we started this deep dive by kind of embracing the complexity of the brachial and sacral plexuses, and we've really seen how that detailed anatomical knowledge isn't just trivia. It directly translates into effective, evidence-based ways to help people with these three major nerve compression syndromes.
Absolutely. The anatomy informs the treatment. Now, for a final thought, something for you to really chew on.
Okay, lay it on us.
We spent most of our time today talking about how massage influences the periphery, right? How we physically ease the constraint on the nerve at these choke points, the wrist, the thoracic outlet, the piriformis.
Yeah, the mechanical effects.
But remember, your nervous system is built on rapid communication. Think about spinal reflexes, like the flexor reflex, pulling your hand from a hot stove instantly, or reciprocal inhibition, relaxing the opposing muscle. These are fast, automatic pathways.
Okay.
Now, if chronic nerve compression exists, the central nervous system, the brain has to constantly work to sort of manage or fine-tune those quick spinal reflex patterns to deal with the ongoing pain signals and altered movement. It might be inhibiting certain reflexes or facilitating others abnormally.
Trying to compensate for the peripheral problem.
Exactly. So consider this. How might your hands-on work at the periphery, reducing that pain, decreasing the compression, restoring normal tissue glide? How might that actually help the brain?
How?
By reducing the noise from the periphery, could you be making it easier for the central nervous system to normalize its control? To let those underlying spinal reflex motor patterns function more efficiently and appropriately again without needing constant top-down inhibition or alteration.
So working locally might actually help reset the central processing.
That's the provocative thought. It's the potential link between the anatomy you're learning right now, the hands-on techniques you're practicing, and the deeper functional neurological rehabilitation you're actually delivering. It connects the periphery back to the central command.